Hello, this is Dr. Gay from First Take MRI, and this is a 22-year-old female who lacerated her fifth finger. She can no longer flex her fifth finger, so the surgeon is worried about flexor tendon injury. And we see here on this axial T2 fat set sequence, we're looking at short axis. We see the fourth finger. This is the proximal phalanx. Here's the fifth proximal phalanx. And we can see the abnormal tendon here, the fifth flexor tendons. And also the fourth flexor tendons also are injured, it looks like. And then here we can see a more normal appearance of flexor tendons. The third flexor tendons, we have the superficial along the top here, the deep there, and they look like they blend together into one tendon, but these are two separate tendons. Here we can see them separated by fluid, and they really stand out as two separate distinct structures. And in the fourth, we can see it's also injured. We have the profundus, deep, the superficialis, superficial, and the fifth one, they look abnormal. The superficialis, there's a little piece of it over here. It looks like it's partially torn and attenuated. And the profundus is also difficult to see here. And we'll look at that a little bit better in a minute. But if we go down towards the palm, we see the two of them, profundus, superficialis, surrounded by fluid here in the tendon sheath. If we get into the palm, a little bit of redundancy. Looks like it's partially torn, but really this is probably just related to recoiling upon itself and redundancy. And it makes it look strange like that. Also fluid in the tendon sheath. One note of caution here, this flexor digitorum superficialis of the fifth sometimes can be really small and even variable. So I've been fooled before. I could barely see it or not see it. And if it's not surrounded by fluid, then it can be really hard to see. So if you don't see it, don't worry, because it may just be really tiny or not present or just to blend with this. So now we're going to go back distally into the hand. And we're going to look for the fourth here. So the fourth, we have the superficialis. Now this is going to go and attach in the middle phalanx. So here we're right before the PIP. Going to the PIP, we see it here smiling at us. There it is. Now it's going to have an opening in it because the flexor digitorum profundus has to go through this opening. And it's going to span out and attach over here and over here. So this midline opening is normal. And again, that's where the profundus is going to go through, but we don't see the profundus going through there. So the profundus is completely torn, and the superficialis looks pretty good here. So this is the, right here on the outside and inside, we see the superficialis attaching. We're going to go more proximal, try to find them. Branching out, attaching here again. And now we're going to look for the profundus. So again, the superficialis here, we're going to go backwards, and the profundus should be coming up here. There it is. So here's the torn end, retracted back. And the profundus is going to go through this opening, and it's going to go distally, and it's going to attach over here. This is the distal phalanx. So it is torn completely from the distal phalanx and retracted back here. So we're going to look on the sagittal images for this. And unfortunately, we didn't get all the way through this. They were only looking at the fifth digit, but here's the profundus. The superficialis is here along the palmar aspect. The profundus is deep right here, and there's the end retracted right back there. So the profundus should go all the way through here. It should go through the opening in the superficialis, and it should attach way over here in the distal phalanx. The profundus goes over, and it's going to separate and attach right here at the middle phalanx, right along the proximal to mid aspects of the middle phalanx. Now we slid over to the fifth digit. Now the fifth digit, we can see similar things. This is the profundus here, deep, and this is part of the end right here, maybe part of the end over here as well. It's hard to tell where, if this is the end or this is the end, but it is torn here distally. We have a little bit of meroedema along the distal phalanx where it attaches. Sometimes this piece of bone can be torn and retract back. We see meroedema, but I don't definitely see a bone fragment that's retracted, but that would be hard to tell in MRI anyway. And it's retracted all the way back here to just proximal to the PIP joint. The superficialis, we really don't see that well either, so it is partially torn as we saw in those axial images. And this may be a little fragment of the profundus here. And this is where that injury is. Now we're going to look at this in axial images. This is the distal phalanx here. We're going to go proximal. Now we're into the joint right here. We're going to look for that profundus tendon. There it is right there. It looks like it's intact. If we go down, we see a fluid-filled gap there. There's emptiness. That's where the profundus is completely torn, lacerated, and it's retracted down to right there. It starts to come back together. And again, the superficialis, which we should see like this, over the top is abnormal in morphology, so it's partially torn. And these injuries are called jersey fingers because they're common in football players. They'll reach over to grab someone's jersey and they'll tear the flexor tendons. Usually it's the fourth flexor tendon that is torn 75% of the time. And the important things for us to know are where is this torn to tell the surgeon and where it's retracted to, because there are surgical implications. If it's just retracted down here to the level of the opening, they don't have to be too rapid at getting it fixed, but if it's retracted all the way down to the palm, it can compromise blood supply and then may need to operate on it sooner than later. And of course, the surgeon will need to be able to find the torn end and know where to reattach it. So just to mention again where it's torn, how far it's retracted, where the torn end is, you think, and also if there's a bone fragment retracted along with it. And that'll help them do their job. And that's it. Thank you very much.